Well, let's get going, everyone. Welcome. This evening, it is a real pleasure. We have Dr. Feza Remzi here with us, talking from New York. He comes to us from NYU. For those of you who don't know, which that's sort of a joke because we all know who he is, he completed his training in medical school in Turkey, and we were fortunate enough for him to come here to the United States and spend his time training at the Cleveland Clinic. After rising through the ranks at Cleveland Clinic, he now serves as the director of the Inflammatory Bowel Disease Center for NYU. He is a world-renowned expert on the ileal pouch anal anastomosis, and we are so honored to have him here tonight speaking to us and sharing the sort of leading opinion on anything that is involved with the J-pouch. So thank you so much. We appreciate your time, and I'm sure there will be a lot of questions in the chat box. Dr. Remzi will field them sort of at the end. So everyone stay tuned, and he'll have the floor for the first part and give his talk, and then we'll get to all of the questions at the end. So thank you again. We appreciate you, and please take it away.
Thank you so much for that kind introduction, and privilege is mine. It's so nice to see a much younger faces than me. And I've been humbled to be part of the training of the many fellows and colleagues throughout the years. And I take these type of offers very seriously. And this is no spin zone. And I like to be challenged with the questions, asked with the questions. But in the next 30 minutes, I will tell you what I have learned through my patients in the last 26 years, that the best way that I believe to serve these patients, that may be open to debate, but I will also give you the rationalization and thought process, the reasons behind that, rather than I said so. So once again, I'm very much humbled for this invitation, and I thank everyone for this invitation and being here tonight in that sense. I have nothing to disclose as a conflict of interest. So we talk about the ulcerative colitis surgery or the J-pouch surgery. I do call, in my opinion, the total proctocolectomy and ileal pouch anal anastomosis is the gold standard for this procedure. Now, these are the other options, and most of the cases that we do at NYU, we do as a 3-stage, and the initial stage can be on a subtotal colectomy with the endoleostomy, and the patient has the right to live like that if they're happy, do not want to go another big surgery to construct a J-pouch or because they're too high risk. In the past, before the J-pouch era, we used to do a lot of the total abdominal colectomy and the ileorectal anastomosis in the past. So that was a gold standard at that time to a certain extent because people didn't know the J-pouch. And when you took the big burden of the disease, you were able to still control the disease limited to the rectum and treat the patient, because a lot of young patients with ulcerative colitis wanted to avoid a permanent bag. And they sucked it up, deconditioned, and tolerated it, but they didn't have the toxicity related to pancolitis. More and more, this is coming back into the equation, especially in the Scandinavian countries, and also even the Cleveland Clinic. We published a paper in a high-risk patients who wants to get pregnant can be an option. If you ask my opinion, if somebody today's DNH is a good candidate for an ileorectal, that's likely a Crohn's disease rather than the UC. So I caution the liberal advocacy of this procedure as a possibility to replacing the pouch, where you're leaving a sick rectum behind and trying to skip the day. So there must be a very good reason. Either the patient is adamant about that I want to get pregnant, I don't want to take any risk of decreased fertility chance, or likely they have a Crohn's disease that is probably a rectum that's spared. That's my opinion. Now, total proctocolectomy and ileostomy can be a very great option in many patients if they already made peace with themselves, or they are high morbid patients that cannot handle a J-pouch. Total proctocolectomy content ileostomy, where our host, mentor, and the chair, Dr. Dietz, is absolutely an expert on this thing. And I think it can be a very good option in patients who has a severe aversion to have a permanent ileostomy after a failed pouch, today's DNH, But one thing I caution you, sometimes this thing get marketed a lot. Avoid a permanent bag. The problem with the continental ileostomy, it needs 3 revisions over 10 years time, with the complexity of the procedure it provides. So it doesn't bring an easy, quick solution. The patients needs to be really understanding what they're getting into. So it needs a motivated surgeon and a motivated patient to make this thing a good reason to do so. And today's discussion is the J-pouch procedure, which I generally do believe that this is a gold standard. And my suggestion to people who doesn't believe this is a gold standard procedure, I don't think they should be doing it. A lot of things you hear this on the NHS system and everything that maybe endoleostomy, then don't do it. That send to the people who really actually knows how to do this, because the comparison is really unfair. We can talk about some of the pros and cons, what's the word up that, and the lack of subspecialization in our country and either country in that regard. So the indications for the subtotal colectomy and endoleostomy can be seen here. Patients that are sick, obese, high dose of immunomodulating agents, biologics, high dose steroids, malnutrition and anemia. I have the least concern about staging this procedure by staging one step ahead. Quite all right. Let the patient to be upset to you 5 to 6 months rather than dealing with a complicated nightmare problem for the rest of their life. Now, this is the way how I do this procedure. Initially, I like to leave the rectosigmoid stump a little bit long. The art of colorectal surgery is to be able to think a couple steps ahead. If you leave the stump this low, then trying to dig the stuff in the pelvis is very humbling. Jennifer, can I ask everybody to mute their things if they can, please? And in the way that how the rectum that is tagged, I prefer to leave it above the fascia. So if this ruptures as a wound infection rather than a pelvic abscess that can cripple the patient's life. Now, is there any data to say the fact that that's absolutely the case? Not really, but this has been the habit for several reasons, as what I said. Number one, if this leaks, it leaks as a wound infection rather than an abscess that can make things very difficult. And also, if you leave a long stump, it will make things much easier to find out at the second stage of the surgery to come and mobilize the things rather than trying to dig something at the pelvic rim. And it can get very humbling if this leaks into the surrounding tissues to find that planes to take the stump off the iliacs and the ureter in that case. Is there an issue of leaving the stump like this too long? These patients require any medication. It's very unlikely. In the last 25, 26 years, maybe 1 or 2 patients needed some local therapy, but it needs to be communicated to them. The fact that the next 6 months, you're going to have some drainage from the bottom. Be aware of that. So they are informed about the expected output from this area. Now, when they do the dissection, I do the dissection posterior like the cancer. I do stay like a holy plane. Anteriorly, unless there's a cancer, I do stay posterior to the denumbiliae. I do not stay anterior to the denumbiliae fascia. Laterally, I may get close to the meso. You stay in that plane, whatever the procedure of choice is, robot, IPAA, at the end, you got to do the things right. Stay posterior to the denumbiliae fascia. Anytime that they have a dysplasia or cancer in the preoperative known, then I would do the proper TME in this setting. By the way, why you do this way, so not doing our pediatric surgery colleagues doing by staying anterior to superior rectal artery, so you will not be leaving majority of the meso behind. That can be a concern from the oncologic standpoint of view if the patient has an incidental cancer or dysplasia found out to be in the pathology specimen. I'm a believer of a double stapling technique for many reasons we'll talk shortly. And the way that I have to do that is you need to come down to the levators and a rectal ring. If you come down to that area, then you do a proper ileal pouch anal anastomosis, not a ileal pouch rectal anastomosis. Then you cut, and then subsequent to that can be seen over here. I like to check the level of the ATZ with my finger, like to leave a proximal interphalangeal joint as an area to transect, and I do transect that area. Then I like to use at least 29 on the Ethicon and 31 in the Covidian, to be able to do the double stapling in an anastomosis. Prefer to bring it posterior to the suture line, especially in the female. You don't want to grab the falling vagina into the anastomosis by mistake creating a double stapling pouch, anal and vaginal anastomosis. It's a horrific, disastrous complication that can happen. Check for a leak. If there is a leak, I like to divert the patient for 3 months or so after the procedure itself. This is how we create the J pouch. I like to use the 2 firing of the GIA 100 blue loads because of the small bowel. Then come across the tip of the J pouch with a reload of the PI or the TA or whatever the preference choice of your linear stapler is. Sad to say, Covidian has dropped the production of the PI-30, which is really a full embarrassment because that was one of the best, the linear stapler that was done for the pelvis because it was not being used. It just tells you with humility and modesty, maybe people have not been mobilizing the rectum properly the way it should be down to the left of the interrectal ring, because that device absolutely, in my opinion, and by the way, I don't have any conflict of interest with Covidian, superior than its own products itself. Now, when you come across this area, you got to make sure that you leave the meso longer part, can be seen here, than the tip of the J pouch, because this can be a catastrophic complication for the tip of the J pouch leak. It can be insidious, tough to find. Your anastomosis looks good, your body of the J pouch looks good, but this can be a very insidious abscess area. It can happen up to 1% of the time of the patients. Check for a leak. If there is no leak, then I like to give an ileostomy. This is that insidious leak that I'm showing about one of my patients that we looked. And what you do, don't kid yourself, these things don't heal. So if you put an IR drainage in these settings, then I think it's very critical to make sure not to pull that drain or study the drain before you pull it, prove where the leak is, because that leak usually don't heal. So don't close somebody without the tip of the J pouch leak. You need to go and do a full proper lap, like in this case, repair the leak, close the ileostomy same time, or keep another 3 months to be able to close it after the things heals up. So insidious problem, leak. So always leave the tip of the J pouch, meso being here, tip of the J pouch being here, so it has less likely getting leak in this area because the blood supply is higher in the meso itself. This is how I create the J pouch, 2 firings of in the past, I used to do the old 3M product, ILA 100. The tips were thinner, but now they also stopped making the linear staplers for that. So I use a GIA blue stapler for that. As can be seen here, make that thing like that. This is an old simulation, like to be able to tip of the J pouch to be able to have a less of an issue with the leak. Now, we're gonna come to this point, and this is one of the most common phone calls that I get still in my career. Number one thing, do not panic. You're not alone. It happens to so many people. So what are the basics of the things that I like to share? I'm a believer of taking the ileocholic artery. You take the ileocholic regularly, routinely at the time of the colectomy. So when you do the ileostomy as an endoileostomy, 6 months, that meso really elongates well around the ileostomy. So that's one. So I do not leave the ileocholic intact at the first colectomy surgery. You did that. That doesn't work. Then you do this scoring along the superior mesenteric artery. This simulation is a little bit misleading. You don't try to make a hole. It's misrepresentation. They didn't know how to do that at the earlier phase of this virtual simulation video that they did. So you score along the mesentery and you try to transluminate with a light cord, take the headlight ahead of the field so you can see the shadow of the superior mesenteric artery so you don't ding it. So that gives you another inch or 2. If the things do not work in this setting, then S pouch can be an option where it gives another 2 to 4 centimeter of a distance to overcome. Now, why S pouch and why I take the ileocholic artery? Because it's kind of close to being impossible to create an S pouch if you don't take the ileocholic artery. Now, if you go back in that, yeah. So if you go back, one thing that I like to share, that it's okay to take the ileocardiac artery, or if you want to keep it, I'm not a believer of an S pouch, keep the ileocardiac artery. You want to take the SMA here. One thing is, be aware, you cannot take both of them. It will be a dismal thing. You'll be looking at the dead pouch on your face. So you're either going to take the ileocardiac artery or you're going to take the distal limb of the superior mesenteric artery. When you do the S pouch, which means that you have to take the ileocardiac artery, they created 12 to 15 centimeter each limb. And the first pouch was done as a S pouch, actually later on with the Japanese invention that turned to a J pouch because of the ease of use, and the results are pretty much the same. You cannot leave this thing more than 2 centimeters. If you do, then you get into a problem with the outlet defecation issues, and it doesn't happen a year or two. Most of the S pouches that was done in 1978 in the first article, according to Prof. Nichols, all those things caught up to a point many years down the line. So you may get the honeymoon for 5 to 10 years, but most of these patients, they're going to show up with a dilated pouch and a dilated small valve due to outlet obstruction. It's a similar scenario, Colorado Dam, Colorado Lake, and the Colorado River, the way that how it becomes really big by time with the obstructive defecation. Double stapling anastomosis, as what I said, come posterior to the suture line. That I like to use this double stapling, again, either a Ethicon 29 or Covidien 31 is my preference. On an adult, I don't believe going less than that. It will create a problem in pediatrics. You may go down to 25 or so as a stapling. But I do believe less than this will give you a problem with the stricturing issues. This is the devastating complication. Be careful, the vagina is really off. Otherwise, you create this, ileal pouch, anal, vaginal anastomosis itself. I like to divert my, patients selectively, and most of the time as a 3-stage procedure. I rather deal with a complication of the ileostomy or ileostomy closure rather than a leaking pouch that can be devastating. And when the pouch leaks, whatever you do, the functions are worse compared to a non-leaking pouch. Ileostomy may not avoid the leak. Ileostomy avoids fecal peritonitis, so it minimizes or decreases the septic impact on the surrounding tissues, which I do believe it impacts the functional outcome in the long run. In order to check for the leak, symphysis pubis association and symphysis pubis orientation, people say 2 centimeters below. I think it's good for a stapled pouch, but for a mucosectomy, if you want to do a true mucosectomy, you want 100% reach, it needs to be 6 centimeters distal to the symphysis pouch, symphysis pubis. What I do is I put my finger to the patient's anus and get a Babcock of the pouch and try to simulate if the things do reach. If that's good, then you're safe. That's the technique that I use to make sure the reach is not an issue. If the things don't work out, then you get into a leak issue like that. For example, this was actually what I mean by that. The double stapling did not work. You have a leak. Commonly, most of the fellows I had the privilege to train, or the residents, immediately people give default, I do a mucosectomy and hands-on. I think the hands-on will be a fair option, but trying to do a mucosectomy is going to give you further disaster, because then you have to overcome another inch or two of a distance. So don't do a mucosectomy if the pouch anal anastomosis on the double staple, you get in trouble. One option is you can do that initial stapling technique, which is a single stapling technique. You got to make sure you start the purse string anteriorly rather than posteriorly, so you don't suffer by getting the nut down behind the anvil. You want to do it anterior to the the anvil to tie the things down. I like to put the stay sutures, 2 or 4 of them, or triochromic, to be able to do the this purse string. Just take your time. Take your time. If that doesn't work, then you can do a transanal approach, can be an option. I'm a believer of leaving the meso posteriorly, because the art of colorectal surgery to think a couple steps ahead, and consider the fact that some patients, up to 15%, may leak rates in different series in the de novo pouches, may have to come back. It's much easier to take the meso off the sacrum, because 60 to 50% you can use the old pouch. But if you leave the serosa on the sacrum, then it will be really difficult to take the pouch off the sacrum by getting to it. So I like to leave the meso posteriorly rather than anteriorly. Some of the tips that may be worthwhile for the time of the boards. So you get in there, you make the judgment, you remember all the things we talked about. If the things did not work out, and then you stapled that area, just leave it there. Leave as an endoleostomy, tell the patient to lose weight and have them to get active, come back in a year or two and put something like an Omentum Cepra film, or to be able to push the bladder and the vagina from the pelvis. That may be easy to find. Let's say the fact that you forgot all the things we talked about. You did an endoleostomy, you excise the pouch, you do the mucosectomy, it doesn't still reach. The pouch is looking at you, actually the endoleostomy looking at it, try to put an Omentum through the anus, put some Cepra film, and then come back again down the line. That is really the toughest and worst case scenario. You did the pouch is looking at you, you're looking at the pouch, and things don't reach. Take a deep breath. Common mistake, default extrapyramidal move, people excise the pouch. Don't do that. Retreat is a sign of maturity. Leave the pouch with a staple at the end, put some technical sutures, but you could close the aperture so the pouch doesn't leak. Bring a loop ileostomy. It will elongate down the lines and you come back a year or two down the line. If nothing works, if you're capable to do a continent ileostomy, that can be an option to consider. Let's talk about some of the controversial topics in the total proctocolectomy and J-pouch procedure. Is it okay to do in the elderly population? The oldest person I have done 81. I don't use as a, the generic age, I use a physiologic age. Comparable morbidity, if the function is a little bit worse, but that doesn't reflect on the quality of life. So it can be done, but don't do somebody on oxygen on a wheelchair. You need to pick the right patient who's motivated, and this needs to be a patient-driven agenda, not by a surgeon-driven agenda. Sometimes people do these studies to find out the fact that the results will be very obvious. Don't do it in the setting of a toxic colitis. These patients have a very bad outcome, and it's no reason to do these things. These patients leak. These patients require a lot of reoperation. Just stage the procedure and go back 6 months down the line. I do not go back in 3 months. I do go back in 6 months after the initial colectomy to take the things down. If something doesn't fit, I may go 5, but I'm reluctant to go anything less than 4.5 to 5 back into a patient that has been sick too long. Now, the other thing that I like to go, that can this be done in the setting of the cancer? The answer is yes, but you do not give in the oncological reason that you're there. As long as you can obtain a proper ontological outcome, it's okay to do it. These are some of the studies that was done. Be aware due to different reasons, oncologically, chemo, old age, cancer, these patients may have a pouch failure rates. One thing is that people also needs to be informed. There are 6 or 7 patients who were radiated after the J-pouch procedure. Be aware these patients do not do well. All of them lost their pouches or ended up with a ileostomy. So if you're going to irradiate somebody, you got to radiate it before the J-pouch. If somebody came with a lymph node positivity, you don't radiate them. You just give them a chemotherapy as long as the margins are negative. Now, one thing is that one of the things that came out, and I'm going to talk about recently, ECHO guidelines. Now, in one way, I'm agreeing with this thing. IPA may be constructed using a staple or hands-on technique. I agree with that, with a comparable functional outcomes. I do not agree with that. It turns to that one needs to believe their study results. And I'll tell you, the studies that we have done and many others saw the fact that staples are superior when it comes to function comparing to a hands-on anastomosis. Now, of course, the anastomosis should be left to the surgeon's discretion, but not because of the fact that it gives an equivalent functional outcome, because the indication for concern for a PSC, cancer or dysplasia. So I like to make sure all of you remember this thing, the fact that I am not agreeing with this recommendation of the ECHO guidelines that the hands-on and staple technique is the same. Why? This is a study that was done, then our research fellow, our current partner, over 3,000 patients. Quality of life is the same. Worse septic complications in the hands-on group and much better function in the staple group. Can you imagine this young population living with a seepage all their life long? I think that is not fair. Now, the mucosectomy proponent always threw this You know, I don't know, I want to call them macho because I don't know there's any female surgeon who does the mucosectomy, but then it's a macho thing that maybe it takes a while to learn how to do a hands-on mucosectomy anastomosis. I'm not buying that argument. With humility and modesty, the proponents of the stapled anastomosis, including myself, have done hands-on stapled anastomosis to be as good as them. So I do believe a proper ileal pouch anal anastomosis, not a ileal pouch rectal anastomosis, has better functional outcomes than the hands-on anastomosis. Now, what's the risk? I mean, this was the big argument from the Vic Fazio and the John Nichols argument, stapled versus mucosectomy. And that argument was the concern for dysplasia on the caphitis. This was the initial study we had done, that no dysplasia, no cancer on the stapled anastomosis. And that is not the case. There has been some staple in that area, but it has shown the fact that the results are pretty much equivalent. Why? Mucosectomy doesn't protect you to avoid not getting a cancer. Why? Surgeons are not computerized machines that you're not going to leave any de novo mucosa in there. In the mucosectomy, then you're shoving the pouch and you're obliterating the mucosectomized ATZ zones, and those islands of cells can become a cancer. So when you look at the review on the mucosectomy patients, they do have as much as of an incidence of cancer developing than this, as much as the stapled anastomosis. So this is my approach currently, whom I pick as a hands-on or stapled anastomosis if it's indicated. And that is if someone has no dysplasia in the colon or rectum, no other risk factors, stapled anastomosis, and do the initial follow-up, and then every other 2 to 3 years. But if someone has a dysplasia cancer in the rectum, not colon, we got rid of that. Dysplasia, my apologies, dysplasia confined the colon to an upper rectum, I still do a stapled anastomosis in these settings. But if somebody has a dysplasia in the or cancer in the lower 2/3 of the rectum, or severe PSC, or FAP patients with a carpeted dysplasia or the polyps, in those settings, I do the mucosectomy hands-on anastomosis. Now, the other thing that came out on this, I'm not picking up the echo guys, that they said that modified 2-stage IPA is associated with fewer complications, non-septic complications with shorter hospital stay than the 3-stage or 2-stage. Once again, this is really misleading. And also it gives a very wrong message. So this is not the one I'm also agreeing with that. That's also another cross, which I forgot the press. Now, you can still avoid an ileostomy. And there's a line proverb, you guys know, certain things in life is being tried again and again and again that it was never done before. Maybe I don't articulate well. I'm going to find that quote by somebody. I mean, this coming back to this concept, it can be done. For heaven's sake, we're in 2021. We have done this thing in 1993 and published another one 15 years ago. You can avoid an ileostomy. Nobody's arguing that. You need to be an experienced surgeon and a humble one. Elective procedure. It needs to be a motivated patient, low dose prednisone, no immunobiologics, biologics, and uneventful operation. So I'm not understanding what exactly the benefit of doing a modified 2-stage in these settings. There is some delusional aspect of the fact that if you don't have the ileostomy, pouch functions immediately, so the pump function better. I would really challenge that, because I have a lady from Virginia who went through this route. At the end of the day, didn't get an ileostomy, septic complication. She lost all her livelihood in a short bowel syndrome because of a septic complication related to that. Now, everybody gives that 1 or 2 complication. It can be done. It can be done selectively. But the fact that to say that it is better than the 3-stage procedure, it's too much. And I completely against that. If any of you guys go and do a 2-stage procedure, get into trouble. And if you haven't done 50 to 60 of a 3-stage or with an ileostomy, I'm not going to be on your side. Be aware of that. And by the way, we're going to send a letter about this thing to the journal, because it's really, what's the right word? Misleading. So Crohn's was the pouch and the IPAA. Can it be done? Yes, it can be done. This is the study that was done many years ago with a brilliant surgeon right now she's in University of Minnesota, Jennifer Melton Mew. Look at this here. If you know the fact that this patient has a Crohn's preoperatively, it's quite all right. You did a 2-stage pouch, pathology came back, Crohn's by mistake, they're all right. The ones that they are not, the patients who already thought that you have an ulcerative colitis, but they didn't declare themselves as a Crohn's disease. They declared themselves many years down the line. Those are the things you cannot do anything about. Pouch retention, 10 years, 71%. So a delayed diagnosis of Crohn's, pouch vaginal fistula, or a sepsis likely due to Crohn's were associated with high failure rates. So you can do patients, you can do a J-pouch in selected patients with a Crohn's disease. To be honest with you, we are pushing the limit a little bit more in this setting because once again, this needs to be a patient-motivated stuff. And motivated stuff is some people cannot live with an ileostomy. If they have a very limited perianal disease, and also backwash ileitis, I may push it. Now we start to put patients on biologic to see. Our early results has been acceptable, but the patients are the one who's going to decide what's acceptable or not. Our job is to sort them with a transparent and honest information what we provide. I'm a believer of a C-section in these settings. However, the data and the literature came up 2007 says the fact that vaginal delivery is safe. I do not want to, it may be safe, but we don't know what's going to happen 20, 30 years down on these patients. So I do believe a C-section. We did the study in the past. We did the blinded evaluation. If the patient, because we didn't know that what type of delivery should be. Some of these patients we served had vaginal delivery. Significant amount of sphincter defect on the blinded ultrasonographer compared to C-section. And then quality of life were the same, except the time trade-off study was better in the patient with the C-section. Functional results, were the same. But some of the things that I believe that in the long term, and also some of the disastrous complications related to vaginal delivery, we prefer to do a C-section when an experienced colorectal surgeon around in that, rather than just saying OB rules dictates everything. We do not do that. Now, let's briefly talk about the reoperative pouch surgery. Now, we do this a lot, and this is not our team's agenda. I'm a true believer of when one can live happily and good quality of life with a stoma, trying to convince them for a redo pouch surgery is a great disservice. It's okay for them to live with a permanent ileostomy, okay? But at the same time, and this is really the argument we can make, that both systems has a good things, a socialist system like the NHS or some of the European system, doctors knows everything, doctor leads everything, versus our system that you can go and find a significantly easier subspecialist in their desire with the insurance coverage that you have. Some patients cannot live with a pouch. So in this setting, with the right selection, it's okay to give them a redo pouch rather than you tried enough, let's do a laparoscopic pouch excision, that's the best for you. I don't believe in that. I think in those settings, you may say the fact that there are few centers who does the redo pouches. Let's have you to send to get an opinion from these centers that may be a value in these settings. Patients should not be slam dunk recommended for a permanent ileostomy, especially if they're a good candidate. Now, when it comes to redo pouch surgery, it's about humility and teamwork. And these patients get to be seen by all of these people, respect to the patient's problem, to the patient's needs, expect the unpredictability. You need to have a consistent operating room staff. You need to strategize that what exactly you're doing for. Repetition is the mother of the skills. This surgery needs to be done in team practice, does it every day, not every day, maybe every week as a group itself. When you do this procedure, I always tell to our fellows and residents, always check your footsteps. This is a technical failure because 80 to 90% of these patients are sent to us with a labeled diagnosis of Crohn's disease. It can be. Now, I throw all the things to a certain extent where the patient's records have. Of course, I go through them, but at the same time, I just sit down and listen to the patient. When did the problems happen? Did the patient have a perioperative septic complication right after surgery? If they did, then that's equal to likely this is a mechanical or technical issues. If patient had great for 6 months to a year without a problem, then the issue started, and you got to worry about Crohn's-like behavior. These patients get worked up with a gastrograph and enema, pelvic MRI, exam under anesthesia and flexible pouchoscopy, and we strategize the plan of care. These are all the areas that things can go wrong, from the tip of the J, the body, to the pouch vaginal fistula complex. And this is the, the abscess they develop with. Briefly about the abscess management. If somebody leaks after the procedure or a pelvic sepsis, we get a CAT scan, POIV rectal contrast. I insist on a rectal contrast. If the rectal contrast does not show any leak and they have an abscess, then they go for a CT guided drainage. If they do have an anastomotic leak, then I try to drain that through the anastomosis into the cavity with a mushroom catheter. But I also tell the patient our plan of closing your ileostomy 3 months is after shoots. It may take 9 months to 1 year to close the ileostomy by downsizing that cavity with periodic every 6 to 8 weeks drain change and finally get rid of it. In those settings, 85% of the time, you'll be able to close the ileostomy. We started to use on a very large big leaks, the Endovac, like a house-made Endovac, because the company pulled it away. You know why? Because the surgeons in this country said that they don't get in a leak like as much as Europe. That's a real story, but that's the reason they were not making money and they pulled it away. Now, coming back to the issue of what I was saying with the pouch excision or redo pouch concept, Europe or other countries versus US. When you look at the rest of the country, so rest of the world, most of the redo pouch studies are coming on this side of the Atlantic or the Pacific. So if it's not coming, there may be two reasons. Either the Europeans are much better surgeons than we are, and some of them may be, you know what I mean, or their system are not palatable enough as a mindset that patients may not be allowed to push the limit as much as it's allowed in our country. So I don't know which one is that. I think maybe a little bit both in one way. But when you look at it, to have them to say the fact that they have around 5 to 15% leak rates, 5 to 15% pouch failure rates, and for them not to have barely any large studies from different countries to add up the studies we have here is something needs to be looked at. Is this, maybe this is the system issue rather than just the surgeons may be better than on this part of the Atlantic issue. So this is the area of where the leaks can happen. So when you do a strategy of the redo pouch, if it's not diverted, we like to divert them for 6 months before considering a redo. Be prepared for the unexpected. Consent the patient for a potential permanent ileostomy or K-pouch. For sure, a permanent ileostomy. Always be prepared for the unexpected. Known to unknown. Circle the enemy. Ureteric stents. Make sure correct the correctables. Excise the pelvic phlegmon in the setting of a septic infection. Otherwise, you're going to shove that pouch there with a significant amount of sepsis and create a problem. It's a common word, dissection, known to unknown. Always have an exit strategy. That's the first thing that I ask when I come to operating room. What is your exit strategy? What's your exit strategy? Pelvic dissection, go down to caudal, come back to cranial. Cranial area where the pouch stuck, the promontorium and iliacs is the worst place. So leave that area alone. So when we do this thoughtful ileostomy, this is the way how we do the things. What does thoughtful means? Because 50% of the time I can use the old pouch, 50% of the time I may not use it. So in that setting, it's better off to locate this ileostomy 6 months before the redo, 20 to 30 centimeter above the pouch, because if we cannot use this pouch, then we can use this site as a stapled new pouch coming down as a new ileal pouch, anal anastomosis. Can be seen here. Again, 50% I cannot use it, and try to bring it like that. It's very critical to do that. And that's the reason we prefer to do loop ileostomy in this setting. But of course, if the patient wants to end ileostomy, as long as it can be done, it can be considered. They just need to be informed the possibility that things may not work, but not to the price the fact that it may not work, that they may end up with a permanent ileostomy if the findings are really bad, if they insist for a permanent ileostomy, end ileostomy in these settings. Now, this is the study I was talking about. Our brilliant postdoc, fellow research fellow, Dr. Esen. We're going to be putting this on a newer version. This was an earlier thing. Now we're up to 170 redo patients. The numbers are the same. Patients who are sent to us, close to 70% of these patients were labeled as a Crohn's disease. Guess what? 85% of these patients were successful. So there's going to be some Crohn's. So don't label the patients as a Crohn's disease when they're not doing well after the J-pouch procedure, especially if they got into trouble right after the second stage or the J-pouch procedure itself, or the symptoms started right after the ileostomy closure or within 1 year. So if the symptoms started within 6 months to 12 months after the procedure, it's more of a mechanical or technical issue. If it's really beyond that, it's Crohn's of the pouch, but patients must be informed that they can have both. So you can fix the mechanical issue. You can always treat the Crohn's. You need to give your gut feeling and your opinion in these settings what you're dealing with, rather than labeling them one way or another itself. This is some of the patients, like it has it all. The long cough, again, this is a pouch rectal anastomosis. It's twisted. I absolutely simply do not like this side-to-side anastomosis at the time of the ileostomy closure. I'm a believer of a hand-sewn anastomosis at this area because it messes up your ability to do different variety of a pouch anal anastomosis. When this is like this, it forces you to go really high up in this area rather than you can bring the things down. And this had to be excised, and we had to untwist it, and we were able to bring it down. So do a hand-sewn ileostomy closure so it doesn't mess the things up in the long run. So there's so much variety of the things that can go wrong. Again, when you do these procedures, you got to be able to do a S pouch because in the re-op setting, the J pouch may not work. It's not like I'm having a stroke. It's just a speedy way of doing the video for you guys to understand. The posterior wall, first wall, then the second wall gets in there, and then you close it. Again, the exit needs to be 2 centimeters before you put the pouch down there. Check for a leak. If there's no leak, you send it. Sometimes the people do end ileostomy, then you have to do a reverse lowercase h pouch can be an option to do so. Our results are not as good as the S or J in these settings. So this is like pushing the limits. So if you can try to avoid a lowercase h pouch, you should, but it can still be an option to consider to do a lowercase h pouch. This is the lowercase h pouch that I'm referring to. Long-term results. This was the earlier study that that we have done before I left Cleveland in 2016. Over 500 patients that and this is, again, out of the 21 people, only 2 or 3 were doing it. So it's very important to centralize it even within the department, and it has very good results can be seen here. Some of these things may not be acceptable for you and for me, but when you look at for these patients, they're absolutely happy about it. Over 90% of it will go surgery again, recommend surgery to others. That's the way to look at it. It's not like what perfect lifestyle should for me. It's about how they can avoid an ileostomy. And I tell them certain things that may not be palatable for us, it can be palatable for them. If you do a good amount of enough, the morbidity of the surgery becomes similar to a regular first-time pouch procedure. So that's the way how I look at it. And also comes to the hands on the stapled anastomosis. When you do these a lot, can be seen the results are similar. And I'm not trying to contradict what I said before. This is in the redo setting that I'm trying to articulate, where these patients are start. So the sicker they are, the level of the functional outcome can become similar. And this is something, 50% we can use the old pouch, which 50% we may need to make a new one, and the results didn't show any significant morbidity in the sense of short bowel or anything in these patients that commonly ask questions in the redo setting. I do believe the redo, something can be done, define exactly what you're calling Crohn's disease, what does the patient want, and that's the number one thing. Work as a group to define whether you can prove or disprove Crohn's. Absence of proof is not a proof of absence when it comes to Crohn's, but you can at least try. Everything is option on the table, and the patient needs to be the driving factor that who wants this redo. I'm humbled to be here, and I'm sorry that I passed the time. Jennifer, I'm going to take all the questions you have. I'll stop. Thank you so much for listening. We're up to 67 participants. I'm very much humbled by this. Thank you.
Thank you. That was excellent. I got to tell you, though, there were 70 at one point, so don't worry. 67 is a little low.
I'm going to call the other three back, just as a kidding.
We do have a couple of questions. These are technical. The first question that we got was whenever you were speaking about tacking the rectal stump. And the question was, do you do this every time?
So this is the thing. I try to do it every time, to be very direct about that. I try to do it every time. Sometimes I go ahead of myself and go lower than what I want, and it doesn't reach. In those settings, I just put a rectal tube in those settings. But I prefer to do it. It's easier to do. I know the MIS and the cosmetic purpose, people can do a single port and everything like that. And that's okay, you know, but this way really helped me a lot, especially on a female. If that thing leaks, it can really mess up the fertility and everything. So I try to do it every time if I can.
Wonderful, thank you. The next question is also technical. What techniques do you recommend for avoiding pouch vaginal fistulas?
Oh, so we have a video we submitted. So I think the critical thing is perfect. You need to be 1 centimeter away from the staple line of the rectal stump. And the other thing that I do is I bring the anvil of the stapler gun posterior to the linear staple line. So there's a little bit more room to forgive, not to do incorporation. And you got to make sure, because I call the Igor intern syndrome, that they move a lot, and you have to have 100% visualization. The vagina is not dropping, double checking the things, putting your finger, making sure to do so. Those are some of the things that I say. The problem, actually, a good question. You need to mobilize that stump to the inner rectal ring. A lot of times that people leave this fibers that goes on both sides of the rectum. You need to tubularize that rectum so the rectum can come all the way off the RV septum 100% to be able to make it free. The other thing that I do when I put the stapler gun, that I brought it down, I call the wiggling move. When you do the wiggling move, that it gives a little bit extra tension from the vaginal wall, so I can dissect a little bit more with a sharp dissection, get the vagina off the linear staple line before I transect it. I know I spoke a lot, but this is a very important question. I want to make sure I gave it. Other thing, Jennifer, that I want to make sure that people understand. I didn't talk anything about open. I didn't talk anything about laparoscopy. I didn't talk anything about robotic. I don't care how you do it, but do the principles that I share. So that's the reason I didn't get into any of these conversations, man.
That's excellent. Sort of building off of that, and you started to touch a little bit on it. What are your thoughts about the mesorectum? Do you take all of the mesorectum every time, or do you leave some behind?
So if it's a cancer or dysplasia, that is correct. I do a proper total mesorectal excision. If it is a benign disease, as what I said, I stay posterior to the superior rectal artery to go all the way. Anteriorly, I do not violate the non-vilea. It may mess up the nerve erigentis in male especially. But laterally, I do leave some, the meso behind, because I don't want to unnecessarily get out of the plane. Those are the things that you can get in the most humbling bleeding sometimes. So I do not do what most of the pediatric surgery colleagues of us still do, with all the respect to them. Because the other thing is that the people talk about with the transanal TME colleagues, they leave the meso, they come from the bottom, they leave the whole meso behind. And that's the reason they put the pouch. They don't give an ileostomy. So the function happens. Oh my God. They may have a different God than I do, but I mean, the problem that I'm trying to make a point that leaving that meso is troubling. The pouch cannot expand properly by times, and the results are very short-lived. And most of the patients who were operated, pediatric surgeons, that way, with the meso left behind, I have taken good amount of them out.
Thank you. We have another question that started with thank you for an excellent talk. Is there a size or BMI that you have as a cutoff you will not operate on due to concerns for pouch reach?
I thank you so much for that question. My cutoff is pretty much after, I tell the patients after the colectomy, I appreciate for this question, by the way, after the colectomy, two things that I have a discussion with the patients, because they would love to eat the world. They are finally healthy. So I tell them, be careful. I give them a cutoff. You can gain 10, 20 pounds, but I prefer to have the patients to come down to BMI of 28, okay? BMI of 28. The biggest BMI that I have done has been 31 or so, but anything beyond that, we have started to send these patients to bariatric surgery, have them to lose the weight and come down and do the surgery down the line. In elective surgery, I am very much reluctant to go above 30, 31.
Okay, great.
By the way, never is never, ever is ever. I never do those answers like that. There may be a variation, but that's usually my generic common ground cutoff.
We have another that says non-technical question for a technical master. When in your life did you find your humility and how do you maintain it?
Yeah, so that's about the team. You know, the point is anytime that you're not humble, somebody about knocks your shoulder and reminds you you're not in charge. And believe me, I have learned that again and again. I'm 55 years old and I'm still learning, and I have so much to learn in my life. I think you rely on your partners, you rely on your team, you rely on your operating room nurses. And people like to say these things casually to fit the common norm these days, but it is really true. When you do these type of procedures, humility needs to be number one norm, but it needs to be complemented with confidence. And sometimes the line between the confidence and arrogance is thin. So you need to make that point clear to the patient and your team. We are there for the patient. We're confident. We can make mistakes sometimes, not being humble or have the humility. Somebody will remind us to get back into track again.
The next one is sort of a comment. Thanks so much for the great talk. You said you use an EEA 31. However, it's always tough to use a big size staple when you do a true anal anastomosis. It always feels you can catch neighboring tissues, including vagina. Do you have any tips for that?
I am hearing what the person is asking a question, but I am respectfully not completely agreeing it. You know, and that is really in a full respectful, I am saying this. We need to be mobilizing because 31, 29 are pretty much the same. So the mobilization is the key, and separation of the technique that I described on the vagina or the prostate of the anorectal stump are my humble opinions. Except the pediatric population, again, I am saying with full humility, I didn't have a situation that I had to use less than 29 or 31. And I'm saying that full humility.
Here's another, sir. It says, how many J pouches in a year would be an acceptable volume to maintain adequate technique?
So I think this is a fair question, because I think with the fiscal drive of our country and everything, we don't want to make a one center marketing point or everything. And it needs to be a team, because you cannot have one guy doing 50, the other guy is doing 0, and then saying the fact that we do this amount. So this is really one of some things I respectfully suggest society to look into these things without getting the marketing purposes. What other things that we can use? Because if the society don't do it, I assure you, a payer is going to do it in the long run to see what the outcomes in the institutions. I do believe the centers, again, I'm going to say a lot, and a lot of people will be critical, is a group I think we need to be doing between 50 to 100. Now, when it's as a group, you cannot have 20 surgeons doing 1 or 2 a year. This really the tradition that the people treat the healthcare professionals, which drives me nuts, like the airline industry. I mean, there are common things of the airline industry, but it's not the plane we're flying that we know 2 + 2 is equal to 4. There is something divine. There is something integrated to our profession that needs to be passing from mentor to the student. That can only happen by double scrubbing or doing an extra year or 2 to do so. And personally, that's what I did. I did 3 years of that with my mentor. That's what your chair did in the past. And that's what some of the people you did. That is what I believe. If you're going to get into the pelvis, become a re-op or a first-time pouch surgery, I sincerely do believe people will need to have extra training. Respectfully, doing 5 a year quota on the fellowship is not suffice.
That's great. Thank you. Does
Feza.
Oh,
Peter Marcello, how are you?
oh, I am so honored here.
Oh, I listen.
So
I
hey,
haven't
I'm going to
listened to
say
your
you
talk,
haven't
Professor.
changed a bit. You haven't changed a bit.
No,
Peter.
no, look, Greg coming in. Hey,
Just
listen,
like high school.
great talk, and a couple of follow-ups. So a patient with known Crohn's colitis, Feza, anus is fine. What will you tell them the risk is long-term that they will fail their pouch? What do you think is a reasonable number?
I quote that numbers that I sent it on the the Geneva Melton article, Peter, that you are correct. The pathology on the subtotal collectomy came back Crohn's. Is that what you're saying for me?
No. Somebody who comes to your office with known Crohn's colitis. They have a skip area. They have Crohn's colitis, they're failing therapy, and they want a pouch. In that population, what would you quote them the risk of failure?
I pretty much, they behave as much as the UC, as long as they do not have a perianal Crohn's disease, Peter, or small bowel disease. That is really the way that what the study, but I also want to make sure to quote that the patients who really come for that reason is not that high. Specifically, on that paper that over 200 patients, we had only 20 patients like that.
Right. But I just don't want the fellows to think that Crohn's is normally something we consider. It's going to be very selective. And I would tell them there's a chance of failures, at least 1 in 3.
But
what do you think?
I don't know whether I can say that, Peter, but because you're correct, the overall numbers showed like a 71% success rate over 200 patients of the Geneva Melton article. But even on that one, the ones that who really failed the most were the ones that who actually declared themselves later on Crohn's disease, Peter,
I get it.
Happens around 2 to 7%. So even if somebody comes back for the fellows, the reason I'm saying this, do I have 100% ulcerative colitis? I tell them the possibility of further Crohn's
always changes.
2 to 7%.
No, I agree with that. All right, next question, Feza. Pouch dysfunction and inability to empty. 2 groups. Pouches that are now, 10 years out, 15 years out, and they can't evacuate. Are you seeing this group? And do you have any thoughts regarding that?
So that's an excellent question. Certain people, these things do happen mechanical, such as I know what you're coming against, such as a long exit count, like mechanical. And
I'm saying everything looks well, but
I
can't evacuate.
Yes. So why? Why did that happen? So I asked them a significant amount of psychological questions. Have they had the abuse in the past? All those things, get a proper anal manometry on these settings. At the end of the day, let's say the fact that I find everything normal and they were fine at one point, 10 years after the line, they started to behave this way. These are the patients, I look at them and I say, I simply do not know what happened to you. If you want to be redone, get another 10, 20 years, I'm here for you. But this is really not my agenda, I tell them. It is okay to live with an ileostomy. As what I said, this needs to be a patient agenda, and unknown must be shared with the patient.
Right. Next question then. Do you have patients that can only empty via a catheter through the anus with a Medina?
Yeah, so that's usually most of the time there's some mechanical thing going on, and the other
No.
component, I know, but I'm going to come there because that's usually there is something going on. Either they angulated the pouch Peter due to straining, or they got a pouch prolapse related to straining, or they got some efferent lumen they got in the straining, or they may have a simple aneurysmus and they get into that category what you're describing. I may just redo them again, starting with the algorithm of Botox and everything, see how it helps if it doesn't help. Now, one thing that I really want to make sure the point that you made, I may sidetrack a little bit for the sake of the fellows. It has been a common trend in the past. Patients have been told after a hands-on mucosectomy and everything, or a one-stage pouch that with no, the diversion. And a lot of time, I'm not saying we did, you did, or others did. People may love to have the idea of having a no ileostomy, but those patients leak. They got a stricture, and these patients have been told, go and intubate yourself. The more it hurts, the more you're doing. I don't do that. If the patient,
I am with you 100%. I divert every pouch.
No, I want to make sure I'm saying for the fellows.
Yeah, I agree.
I do not recommend somebody to put a tube to the patient's bottom every day. That's so cruel. If somebody is needing that, they need to be considering of a redo.
Yeah. Okay.
Say hello to Brianna.
Yeah, we'll do. All right.
I have another.
Yeah,
I have another question.
Is that did Dr. Mansola crashed the session? But that's okay. I'm just kidding.
That's okay. He had great questions.
Well,
we like it.
We were partners. He was my roommate in the Cleveland. We shared the office together.
Oh, I love that. I love
Best
that.
of buddies.
That's great.
Best of buddies.
Well, thanks for coming. The last question. Do you keep in touch with other surgeons in the country who do redo pouches, and do you like to collaborate? And do you eat lunch with them when you're in town?
Yeah, it depends. I mean, we do work with a lot of people, and then it's really important to collaborate in these settings as a group. Absolutely.
Right. I think that's it. Does anyone have any other questions that's still on? I don't see any more in the chat box. This was an amazing session and tons of pearls for those of us who are training, and we really appreciate all of your insight. So thank you for coming and being a part of our series. And we really just appreciate all of your guidance. And there's questions to us about where the recording will be available. We'll post it onto the virtual education website, so you'll be able to access it there.
Thank you so much for all the opportunity. Thank you so much. I appreciate it.
All right, sir. Thank you.